Hello, and thank you for joining us. I'm Andrew Hanzlicek. I'm the veterinary director at MiraVista Diagnostics, and the purpose of this brief presentation is to review the diagnosis of coccidioidomycosis in small animals, specifically dogs and cats. So we'll talk a little bit about the clinical findings, and that's because anytime we're interpreting a diagnostic test, it's good to have a reasonable clinical suspicion of that disease. We'll talk about diagnostic tests, and specifically we'll talk about cytopathology, we'll talk about antifungal antibody detection, we'll talk about antigen detection, and we'll finish up discussing treatment monitoring and how some of those non-invasive tests can be used there. Coccidioides is a dimorphic fungal organism. That means it exists in the environment in a mold, and once it's inhaled and is in the body, it converts to a yeast. And there's two other important dimorphic pathogens in the US that affect dogs and cats. One is histoplasma, one is blastomyces. Coccidioides or valley fever is not contagious. It's an environmental exposure to those spores. The organism likes alkaline, sandy soils and arid climates. And so it makes sense kind of where that enzootic region is, and that's the hot, dry parts of the US. And so really the biggest hotbed is the Phoenix area and south, but there's plenty of coccidioides in West Texas on into New Mexico, Southern California, up into Utah, Nevada, even up into Washington and Oregon. And really it pops up sporadically in the entire Western US and Canada. So we have to have it on our differential list in those places. It more commonly affects dogs as compared with cats, but it infects both species. Interestingly, cats that never leave the house can develop coccidioides, so I think that speaks to kind of the ubiquitous nature of the organism. The lung is often involved, and this is lung parenchyma, but also intrathoracic lymph nodes, and I'll show you some thoracic rads of that. Skin and eyes, bone, and CNS are other common sites affected with valley fever. Clinical signs can be vague: anorexia, weight loss, lethargy, fever unresponsive to antibiotics. Dogs and cats often cough with valley fever, and I'll show you why. Lameness is common with bone involvement, cutaneous lesions. CNS signs can be variable depending on what part of the brain or spinal cord is affected. And so this, in my mind, is kind of the classic thoracic radiograph with valley fever. I should mention that coccidioides can do anything on thoracic radiographs. Any lung pattern is possible. Pleural disease is possible, pneumothorax, pleural effusion. And so in this case, again, this is kind of what I consider the classic. We have pretty normal lung parenchyma actually in this dog, but we have big, huge tracheobronchial lymph nodes. And these big, huge lymph nodes press on the larger airways, such as the mainstem bronchi and secondary bronchi. And remember that these areas are rich in cough receptors. So dogs and cats with valley fever cough at a much higher frequency than, for example, with blastomycosis or with histoplasmosis. And that's because that's where the cough receptors are. They're in these big airways. These lymph nodes are often big and pressing on those airways and stimulating those cough receptors. Just another radiograph here. You can see the big tracheobronchial nodes, kind of caudodorsal to the carina there, pressing on the larger airways. Here's a dog with primarily lung disease, parenchymal lung disease. We have kind of this unstructured interstitial pattern. There might be a bronchial component, maybe even coalescing in some areas to alveolar disease. So mixed lung patterns are very possible and happen. And in this case, as compared to the last one, this is a very mild radiographic changes, kind of a diffuse, unstructured interstitial pattern. So again, remember that valley fever really can do whatever it wants on thoracic radiographs, and tracheobronchial or intrathoracic lymph node enlargement is common. It really likes the bone, and I think after lung, bone is one of the most common sites affected. In this case, we have a chronic osteomyelitis of the tibia. You can see lots of bony production and some lysis there of the tibia. Here's a humerus. Again, this is chronic, lots of bony production, some lysis. And if you live in an enzootic area for valley fever with a bone lesion, valley fever has to be at the top of the list. It really likes the bone. Cytology. So you can look at these organisms, these yeast organisms. They have kind of a double refractile wall. In some cases, they can be next to each other, looking like they have kind of a broad-based budding, almost kind of look like blasto. Some important differences here. Notice the variable size in the yeast. You'll never see that much variability in blasto organisms. And really the other dead giveaway is this huge spherule here, with endospores. And this one here is ruptured and releasing the endospores you can see on the slide. So really kind of the hallmarks of coccidioides are the variably sized yeast, the spherules, and endospores, along with pyogranulomatous inflammation. And unfortunately, we don't find organisms in every case. And so maybe it's an organ that's not very easily reachable, like the tracheobronchial nodes. Maybe it's an organ that we could sample. We found inflammation, but we didn't find fungal organisms. And that's where non-invasive testing really becomes important. And kind of compare and contrast valley fever to histo or blasto, antibody testing is the first line. And there's really two potential antibody tests available on the market. There's an EIA or an ELISA offered by MiraVista. It has a good sensitivity of about 90%, a specificity of around 94%, and probably the biggest advantage of the EIA is that it has a very quick turnaround time. The test can be done in a few hours, so the turnaround time is generally the day the sample is received. The second test is an immunodiffusion, and it's also a very good test. It's offered by many labs. It has a sensitivity that's similar to the EIA, a specificity that's also similar to the EIA, but the biggest difference here is the turnaround time. The sample has to incubate for a number of days to allow that antigen and antibody to kind of migrate through the gel. And so turnaround time tends to be somewhere between 4 and 7 days. So you're definitely going to have a slight delay in the diagnosis if relying only on immunodiffusion. Now, what's interesting about these antibody tests is that about 10% of dogs will test positive on one but negative on the other, and vice versa. So really the ideal scenario is using both antibody tests. And if you combine the EIA and immunodiffusion, you end up with a sensitivity of around 99% while maintaining a high specificity of around 95%. And that's the ideal scenario. There is an antigen test available from MiraVista for coccidioides. The antigen is galactomannan. And when we use that is typically along with an antibody test in cases of suspect disseminated disease. And the advantage here is that since this is a part of the fungus, since it's a part of the fungal cell wall, it's evidence of active infection, not just a titer, but B, it can be used for treatment monitoring. And so I'll show you how that fits into the algorithm. But antigen clearance is an important part of treatment monitoring if it's positive at baseline. Now, it has a low sensitivity as compared to, for example, blastomyces antigen or histoplasma antigen. And so we really don't use it much for localized disease. It's going to be negative in most of those cases. So really its use is limited to disseminated valley fever. So if we kind of plug that into an algorithm here, we start with a dog or a cat that has suspect valley fever. And if we can get a cytology sample and if we can find the organism, then that's great. That's got a high specificity. We know we need to start treatment. In many cases, either we can't non-invasively sample the organ that's affected, or we do sample it and we find inflammation, but we don't necessarily find the organisms. This is where non-invasive testing, as we've said, comes in very important. And so antibody testing being the mainstay of testing for a single organ disease, we want to choose an antibody test. Ideally EIA, either followed by ID if it's negative or performing both at the same time. That will maximize sensitivity. If we have multisystemic disease or we're suspicious of disseminated disease, then the antibody EIA along with the antigen EIA, again, the antigen test allowing us to monitor treatment a little bit better and proving active infection. If those are positive, along with the appropriate clinical signs, then we have enough there to treat. If those are negative, we could consider retesting antibodies in 1 month. Occasionally, if you catch a dog or a cat very, very early, they potentially have not seroconverted and you could have a false negative on the antibody tests. Might have to consider more invasive testing and fungal culture of tissue or fluid samples in those cases. And then obviously, if all of our testing is not pointing towards valley fever, then we might need to reconsider our diagnosis. Won't talk much about treatment really at all in this presentation. That'll be in a following segment, but I do want to mention that for mild or moderate disease, meaning treatment on an outpatient basis, fluconazole or itraconazole is the treatment of choice, and you could compare and contrast those and probably debate which is the better drug. If you're using itraconazole, it's recommended to check blood levels. And for life-threatening disease, the most effective antifungal, the one that works the quickest, is amphotericin B. And so that's the one recommended for serious life-threatening disease. As far as treatment monitoring, so when to stop antifungal therapy, we'd say treat a very minimum of 6 months. Many animals, especially those with disseminated disease, are going to need a much longer treatment duration. And in some cases, treatment may be indefinite in some of these dogs and cats with disseminated disease. We want to treat at least a month past resolution of clinical signs, at least a month past resolution of exam abnormalities, and at least a month past resolution of imaging abnormalities. And the most useful imaging modality is thoracic rads. If those are abnormal at baseline, I would recheck those every 3 months. And then once the imaging abnormalities have resolved, then we can check that box. If antigen test is positive at baseline, then we would like it to be negative at the time of remission before stopping treatment. In many cases, we're basing our diagnosis on antibody testing. And so we recommend checking antibody titers or concentrations every 3 months. Ideally, we treat until the antibody titer or concentration is negative. But in some cases, dogs will remain very low positive. And so in those cases, we at very least want the EIA concentration to be less than 20. And the ID titer, although this is somewhat debatable and not completely accepted, ideally that's less than or equal to 1 to 4. Anything above that, I would be worried that we have ongoing active disease and would be hesitant to stop treatment. And then again, if we're treating with itraconazole, don't forget to check blood levels. There's lots of variability from dog to dog and from cat to cat in regards to how that drug is absorbed. And we can minimize adverse effects and we can ensure therapeutic blood levels relatively inexpensively with the bioassay. That's all we have for the diagnosis of coccidioidomycosis. At MiraVista, we love to hear about your cases and answer your questions, so feel free to reach out to us either via phone or check us out online at miravistavets.com.